Thank you. Thank you for inviting me here. It's an honor and a pleasure to be here, Daniela, and thank you. So I'm going to present a case, a woman in her 60s with acute angle closure glaucoma, having trabeculotomy in another clinic 10 years ago in her left eye. We see a superior vascular black, flat anterior chamber, meiosis, occlusion pupillae, large anterior synechia on inferior 180 degrees. So this is the anterior segment. You will see several other pictures of the anterior segment, but with good IOP, and fundus, of course, was not visible due to this advanced cataract. The visual acuity was 1/20. Anterior chamber is flat, 2 millimeters. You can see the specular microscopy, 1,100 saboneal cells with a hazy appearance. And of course, we have some challenges in this case. A large bleb with extended anterior synechia. You will see there's really difficult to find a place to perform the incisions. We have flat anterior chamber, low endothelial cell count, mature cataract, small pupil, fixed synechia, and extremely limited space to work in. We have a question. What would you do in this case? Well, the middle step of the surgeries. Injecting oils in OVD, synechialysis, people stretching, tightening, staining, phacoemulsification in the back. Answer number 2, vitreous step, inject oils in OVD, synechialysis, AICCER type of staining, phacoemulsification, bed, IO imputation. Question number 3, option number 3, inject the DAISY OVD, synechialysis, interotomy, stribum staining, phaco-capsular bag removal, and retropupillary iris chloroidal implantation, or other options. Please vote, and meanwhile, maybe the colleagues from the panel can have an option or a comment.
I can comment on that. Albumin is associated to glaucoma. So for this case, I would use iris hook and trap and blue and do the phaco, my routine phaco. But after the phaco, I would use a gonioscopy. I would do an intraop gonioscopy and make sure I do a goniosynechialysis 360 degrees, and also make sure that the austin of the trabeculectomy it's open. And if possible, I would even consider combining with a needle, with a combined needle.
So I guess there's a few questions here. The axial length of the eye is normal or small?
21.
21. So it shows small side. We have to ask ourselves, why is the AC so shallow?
Right? It was not very well seen in this picture. There were other pictures where we can see it better, but you will see it in the video. The iris is attached to the cornea or UV endothelium from 2 o'clock, all the inferior half, up to 8 or 9 or 10 o'clock.
And the central anterior chamber is also shallow.
Yes, the remaining anterior chamber was 2.1.
Okay, so it's not terribly bad. So I don't think we need vitreous tap, first of all, if you have a 2.
Absolutely agree.
I think that a good supervicious cohesive adhesion is good to maintain the chamber. I think you have to manage the pupil, as you said, by doing a little pupil. I would do a gentle release of synechia. I would try to use just a hook to open it up. If hooks are needed, I use iris hooks in that case. And then we do our phaco, making sure we keep the chamber formed. I think doing a goniosynechialysis is a good idea. It's releasing very carefully from the peripheral cornea. And that'll hopefully then allow you to keep the anterior chamber formed. I believe the zonule should be okay, but we'll evaluate. We'll find out about this. And that'll be kind of the first steps in managing this case in approaching this shallow chamber.
I enlarged the previous parasitesis and I transformed it into a main incision to work with, with the phaco tip, and I continue with the more or less standard phacoemulsification. My preferred technique is chop technique. I chop it, but I just went lower with the parameters of aspiration rate and the vacuum. I keep a bit the infusion higher than normal. Usually is 1.0. In this case, I went a bit 1.6, 1.8. And I keeping the chopper in my left hand, very careful to make like a sort of barrage or to keep away the area where the Descemet was detached, because I don't want to detach it more. If you aspirate it or damn it, and I'll tell you my video cord. So I needed to be very careful to keep it as far as possible from the tip of the phaco, which I think I managed. Now, usually I implant IOL with hydrodissection on 2.2 Bundesliga, but in this case, of course, was not recommended. I enlarged the same incision. And as an RVD, I carefully injected the IOL in the anterior chamber and in the back. The astigmatism was the less significant problem of this patient in this case, and I just put a suture which could be removed quite soon here in the anterior chamber. This is how the eye looked the very first day, so extremely nice, unbelievable nice. This is in 5 days post-op. The Descemet, localized Descemet was still there, detachment was still there, but then it reattached, and the anterior synechia in inferior half of the iris were still there. I didn't touch them anymore, but the Descemet membrane was completely attached, and the visual acuity of this patient at 2 months was 20/20 with some correction. Thank you.